So thank you for having me here and for this invitation. The title of my talk is Obesity and Gastrointestinal Disorders. I think many of us take care of kids with obesity who have liver issues, fatty liver disease, but for the purposes of this talk, I'm really going to focus more on luminal GI disorders. So I have no disclosures for the purposes of this talk. The objectives of my talk are to discuss GI disorders associated with obesity, including functional GI disorders. And I'll talk about conditions like functional constipation, irritable bowel syndrome, functional abdominal pain. I do want to touch upon obesity-associated organic GI disorders such as celiac disease and inflammatory bowel disease. We'll discuss possible mechanisms for these potential associations and discuss the clinical implications and significance of the association between obesity and GI disorders. So I think all of you know that the obesity epidemic has been quite significant within the United States. In the past 2 decades or so, obesity and obesity-related complications have resulted in significant morbidity and mortality in adults in the United States. A lot of the complications of obesity results in preventable conditions which can be avoided if obesity is well controlled. There is a growing trend in obesity in the US, and since the early 1990s, the percentage of population with obesity has significantly increased. Now there are considered to be about 35% of the adults in the United States are obese, and which is about 78.6 million adults in the US. But what is interesting is that this is not limited to the Western world. It's not limited to the US. In fact, this is a global pandemic and a global issue. And countries in the Far East which were struggling with poor weight gain, weight loss, malnutrition are showing a higher percentage of population with obesity. So currently there are an estimated 500 million obese adults and an estimated 1.5 billion overweight or obese individuals worldwide. Now, what is worrisome for pediatricians such as us is that this is not limited to the adults. Children are definitely involved with obesity issues. In the US, we sort of divide or understand the weight status category based on the BMI percentile range of children based on the CDC growth charts. And according to the CDC growth charts, underweight is a child whose BMI percentile is less than the 5th centile. A normal weight child is considered to be the one whose 5th to less than the 85th centile. An overweight child is the one who's 85th to less than the 95th centile, and obese is a child who's above the 95th centile for BMI. And based on these criteria, currently per the CDC, almost 17%, which is a big number, 12.7 million children and adolescents in the United States are above the 95th centile for weight. And about 16% of adolescents are overweight. But again, this is not only in the US, it's a global issue affecting both developed and developing countries. More recently, there's been a slight decline in the obesity rates, but in spite of that, the percentage of children with obesity still remain pretty high. Now, there are several complications of childhood obesity. We certainly encounter some psychosocial issues as gastroenterologists. These include that children having poor self-esteem, depression, eating disorders. There are other conditions which cause significant morbidity and maybe even some mortality, such as dyslipidemia, hypertension, type 2 diabetes, coagulopathy. As gastroenterologists, we're seeing more young children with gallstones, which was originally considered to be a disease in adults. And of course, we're taking care of more children with fatty liver disease. Now, recently, however, in the past decade, what we're also seeing is that there is an association between functional and organic GI disorders and obesity and being overweight in children. So, some of the initial data on this association was published in Adults back in 2008, where a meta-analysis of 30 adult studies showed that there was some relationship between BMI and GERD. And in this particular meta-analysis, they actually found that adults who had a BMI over 35, anything over 30 is considered obese, were 6 times more likely to have GERD symptoms, which is, a significant higher percentage. Subsequent to this initial study, there were some pediatric studies which showed the association. All in all, the proposed mechanism for this was thought to be extrinsic gastric compression, such as with truncal obesity, leading to increase in intragastric pressure, relaxation of the lower esophageal sphincter. In adults, they've done some studies which have showed that obese individuals have a higher or increased esophageal acid exposure, sort of supporting this theory. Now, in Connecticut, Pashankar and colleagues did a study where they compared obese children versus controls, which were normal weight children, looking at reflux symptom scores, symptoms of heartburn and regurgitation. And what they found was that obese children were significantly more likely to have a positive reflux symptom score. So big differences, 13.8% versus 1.9%. These kids also complained more of heartburn, they complained more of regurgitation. And what they found was obesity was the only predictor of high acid symptom score. But what was also interesting is that reflux symptoms increased in a linear fashion with an increasing BMI. So in a group of severely obese kids, for example, who had a BMI Z-score of over 2.7, more than 20% of the individuals had a positive symptom score. So that's a pretty big number. More recently, there's a very large pediatric study which was population-based, cross-sectional, and involved almost 700,000 patients between the age of 2 and 19 years of age. They found that a diagnosis of GERD was found in about 1.5% of boys and 1.8% of girls. In this large study, they did not see an association between obesity and reflux in the younger age group, so kids between 2 and 5 years of age. But what they did find was that there was an increased risk of GERD in moderately to severe obese children, especially between the ages of 6 and 19. So you're more likely to have issues if you're more obese and of course older in age. Now, adult studies related to obesity and acid reflux have shown that adults who have a higher BMI not only have more acid reflux symptoms, but they're more prone to complications related to acid reflux, such as erosive esophagitis, Barrett's esophagus, esophageal adenocarcinoma. Thankfully, some of these are not pediatric issues that we have to deal with. There are a couple of studies which are small retrospective studies that have looked at obesity in children and their relationship to more objective issues such as reflux esophagitis, and they have not been able to find any association between the two. Now, similar to the positive association between obesity and acid reflux, there seems to be some relationship between obesity and constipation. And all pediatric studies in the US have showed this positive association. We did a cross-sectional study of children in Connecticut. We enrolled about 450 children from our local pediatric primary care clinic and also from a local pediatric practice. We used the Rome-3 criteria, which are the validated criteria, to diagnose functional constipation. And overall, we found that the prevalence of constipation, as expected, was fairly high and similar to what other studies have shown, about 18%. But what we found was that obese and overweight children had a higher prevalence as compared to healthy, normal weight children of having constipation. So 23% versus 14%. Now, there is some association or studies that have looked into obesity and abdominal pain related functional GI disorders, specifically conditions such as irritable bowel syndrome and functional abdominal pain. The data on these is fairly limited in the pediatric population. In adults, the data is conflicting on obesity and IBS, but the pediatric data, there are only 2 studies. Both have shown that there is a positive association between the two. But again, we I think, need more evidence to really confirm this association. In regards to functional abdominal pain, again, the pediatric data is very limited. However, an initial study by Malati and colleagues showed that there was a positive relationship between obesity and recurrent abdominal pain. They did not, however, define abdominal pain or functional abdominal pain per the Rome 3 criteria. So when validated criteria were not used, there seemed to be some association between obesity and abdominal pain. Subsequently, there were 2 more studies in the pediatric population which looked at obesity and functional abdominal pain based on the Rome 3 criteria, and they were not able to show this association. It's unclear why we're seeing more association with irritable bowel syndrome versus functional abdominal pain. Now, what is really more interesting is the issues with obesity and organic GI disorders. It almost sounds counterintuitive, but this is what we're seeing more and more in our practice. So this is just a little picture to show the old celiac disease. These are the classic textbook pictures that we see in GI textbooks showing malnourished children, children with nutrient deficiencies, who are then diagnosed with celiac disease and undergo a remarkable change when they are placed on a gluten-free diet. But really, this is the new age celiac disease, and there's a changing look for celiac disease. So I think the vast majority of the kids we see with celiac disease fall somewhere, in this category where they look like very healthy, normal children. But what's interesting is that now we're seeing children who also look like this, who ultimately get diagnosed with celiac disease, where weight loss, poor growth was the more classic presentation. So there are a few studies which have looked at the body mass index status in celiac disease. There are about 5 of them, and what they have found is that the rate or prevalence of overweight and obesity at presentation or at diagnosis of celiac disease can range anywhere from 5 to 19%, so significantly high numbers. But what is interesting is that a few of these studies actually show that children at diagnosis are more likely to be overweight or obese rather than being the classic underweight presentation. And another very important feature is that these studies show that some of the kids who get placed on a gluten-free diet then develop obesity, which underscores the point that Dr. Porto made earlier, that when you place a child on a gluten-free diet, whether they have celiac disease or don't have celiac disease, careful nutritional monitoring is very essential. Now, similar to celiac disease, traditional symptoms of inflammatory bowel disease include weight loss and poor growth, in addition to the classic abdominal pain, bloody diarrhea. But more recent studies are suggesting that obesity is not an uncommon finding. So Moran and colleagues did a time trend analysis looking at what has happened to the BMI over the years in children who are diagnosed with inflammatory bowel disease. And what they have found is that there is an increase in BMI over time, as well as overall weight of patients who get diagnosed with inflammatory bowel disease. In children, there's a study by Kugathasan and colleagues which show that 10% of Crohn's disease patients can in fact be overweight, and overall 30% of patients with inflammatory bowel disease can have issues with overweight. African American race having Medicaid insurance positively are related to overweight and obese status. So what are the possible mechanisms of this association? Why are we seeing more and more overweight, obese children have GI symptoms? And I think there are a few proposed theories. We don't have clear, definite evidence that this is what is causing this particular association. We don't know if it's a cause and effect relationship. We don't know if the association is merely spurious, but we definitely know that these two can be related. One common factor could be the effect of diet. So for example, in children with irritable bowel syndrome who have diarrhea predominant irritable bowel syndrome could potentially be consuming foods that are high in sugar, leading to abdominal pain, leading to diarrhea. And children who eat excess fat, low fiber, are obese could very well have symptoms of functional constipation, where the low fiber contributes to decrease in gastric motility and hence constipation. These are very important factors to keep in mind, because often children who are obese and overweight have psychosocial issues. And when kids have these issues can also cause GI problems. So definitely this could potentially be one missing link between the association. Neuropeptides such as leptin and ghrelin have been indicated. These are peptides which regulate satiety, feeling of hunger, and a dysregulation in these hormones can predispose kids to eat more and then potentially subsequently have more GI problems. And then ultimately, people have talked about the role of gut microbiome. As we all know that there is some dysbiosis that could potentially be resulting in obesity and of course, ultimately in the cause of GI problems. Now, we don't know the exact mechanism of association between obesity and organic issues such as IBD and celiac disease. One simple explanation could be that it's merely mirroring the general trend of obesity in the population. What studies have shown is that in children or in adults with celiac disease, they're more likely to be obese if the diagnostic workup was based on positive screen rather than clinical features. So an incidental finding of celiac disease, that particular patient is more likely to be on the heavier side. So what is the significance of this association? Why does it really matter? How does it have implications on our practice? And in our particular study, what we found was when we compared the percentage of having at least one functional GI disorder in obese and overweight children versus normal weight children, obese and overweight kids were almost twice as likely to have at least one functional GI disorder. These are kids who already have significant morbidity and mortality related to obesity, and I think the presence of additional GI problems can add to that morbidity and potentially to their day-to-day life and quality of life. So an important thing to remember, an important thing or association to be aware of. Pediatric data suggests that obesity adversely affects the outcome of GI disorders. So children who are obese and have pain have a higher frequency and intensity of pain. They're more likely to miss school. They're more likely to have disruption in their daily activities. Mishra and colleagues showed that obese children with constipation were in fact more likely to fail therapy. So really awareness is important as the first step. Prompt therapy is extremely essential to maybe improve some of the morbidity and then ultimately improve the quality of life and well-being of these children. Now, in our study, when we compared the presence of a functional GI disorder between obese overweight versus normal weight children, what we found was that, of course, almost 1 in 2 obese overweight children had a functional GI disorder, but only about a third of these patients had approached a gastroenterologist or seen a gastroenterologist or even talked to their primary care provider about their symptoms. Now, the association between obesity and organic GI disorders is definitely noteworthy. The important thing is that even in organic etiologies, you should consider organic issues in appropriate clinical settings in spite of the presence of obesity. Children with celiac disease are likely to be overweight or obese rather than being underweight. So that's another important point to remember. So you shouldn't disregard diagnosis of organic issues based on the BMI or the appearance of the patient. And then ultimately, close nutritional monitoring on gluten-free diet is very essential given the concern for development of obesity or a higher weight. So in our program, the dietitian certainly counsels patients on eating a healthy gluten-free diet, and similar to a normal diet, we suggest that their diet should be moderate in cholesterol, moderate in protein, low in fat, sodium, alcohol, especially concentrated sugars, and ultimately high in fibers. We try to give them recipes, ideas, so that they can eat a variety of foods for a good nutrient balance. I think Dr. Porter talked briefly about this, where there are certain grains and seeds which are high in nutritional density and quality. And grains and seeds such as amaranth, buckwheat, teff, quinoa, soy are supposed to be very good. They're higher in protein and amino acids, they're moderate in carbs, they're good sources of calcium, iron, and then they're low in sodium. So we try to counsel patients that these are the type of foods that they should be eating. We provide them with recipes for the same. An important feature of a gluten-free diet is that sometimes gluten-free flours can result in excess calories. So often gluten-free flours are rice and corn, and these can result in higher caloric intake and weight gain. So remembering that is important. Now, adult data has suggested that there is some issue or worsening of disease activity, perianal complications, and worse morbidity in adults who have inflammatory bowel disease and are obese. Adult data also suggests that high BMI related to IBD was related to IBD-related surgery, longer operative time, and blood loss. In children, there is no significant association that has been shown, although the data is quite limited, between obesity and IBD disease severity and surgery. But irrespective of this lack of association, nutritional counseling, weight loss management are very important, because again, kids with IBD have significant morbidity, and now add to that issues related to obesity. So definitely this is something that has to be addressed. We have a multidisciplinary program for IBD patients at Yale, and our nutritionist is usually very careful about giving appropriate nutritional recommendations when we encounter such issues. I think it's also important to remember the role of features such as ethnicity in our practice. Typically, the African American race as well as Hispanics are thought to have more issues with higher weight gain and weight issues. So especially if you're seeing these individuals or you're practicing in more indigenous areas, these are, awareness of this association is very important. So in conclusion, there definitely seems to be some association between obesity and functional or organic GI disorders. Again, we don't know whether there is a cause-effect relationship between the two, but definitely there seems to be some association. Most importantly, you should consider diagnosis of organic GI disorder even if a child appears to be overweight or is obese. And then awareness of these associations is needed for optimal management and overall well-being and quality of life of obese children. Thank you.